Below is a complete expanded version suitable for a nursing case presentation, class report, or research paper. Pulmonary embolism. 1. Introduction. Pulmonary embolism, E, is a sudden blockage of the pulmonary arteries in the lungs, usually caused by a blood clot that travels from the deep veins of the legs, deep vein thrombosis, DVT. It is considered a cardiopulmonary emergency that can cause significant morbidity and mortality if not recognized and treated promptly. PE interrupts blood flow to part of the lung, leading to impaired gas exchange, hypoxemia, increased pulmonary vascular resistance, and right ventricular strain. Depending on the size and location of the clot, clinical presentation can vary from mild shortness of breath to sudden cardiac arrest. PE is part of the venous thromboembolism, VTE spectrum, which includes DVT and PE. The condition represents a major global health concern due to its high prevalence, diagnostic challenges, and potential for sudden death. Definition. Pulmonary embolism is defined as the occlusion of one or more branches of the pulmonary artery by a thrombus, fat, air, tumor cells, or amniotic fluid that has traveled through the bloodstream from another part of the body, commonly from the deep veins of the lower extremities. The obstruction reduces or stops blood flow to a portion of the lung, impairing oxygen exchange and increasing pressure on the right side of the heart. Etymology. Pulmonary originates from the Latin word pulmo, meaning lung. Embolism comes from the Greek word embolos, meaning stopper or plug. Thus, pulmonary embolism literally means a plug or blockage within the lung's blood vessels. Number 4. Epidemiology. The annual incidence of PE is estimated at 6 to 70 per 100,000 people worldwide. PE accounts for 10 to 15% of all hospital deaths and is the third most common cause of cardiovascular death after myocardial infarction and stroke. Mortality rate, untreated PE, up to 30%. Treated PE, less than 10%. Gender, slightly higher in females due to hormonal factors. Oral contraceptives, pregnancy. Age, incidence increases significantly after the age of 60. Hospitalized and immobile patients have a higher risk. Number 5. Types of pulmonary thrombotic PE. Most common, over 90%, originates from DVT, especially in legs or pelvis. 2. Fat embolism. Results from fat droplets entering the bloodstream, often following long bone fractures or orthopedic surgery. 3. Air embolism, caused by introduction of air into the venous system during IV infusion, surgery, or trauma. 4. Septic embolism, occurs when infectious material or bacteria travel through the bloodstream, e.g. in infective endocarditis. 5. Amniotic fluid embolism, a rare but catastrophic condition during labor, delivery, or postpartum when amniotic fluid enters the maternal circulation. 6. Causes: deep vein thrombosis, DVT, prolonged immobility, e.g. long flights, hospitalization, paralysis, recent surgery, especially orthopedic, pelvic, or abdominal, major trauma or fractures, especially of long bones, malignancy, cancer increases coagulability, pregnancy and postpartum period, use of oral contraceptives or estrogen therapy, obesity, heart failure or atrial fibrillation, central venous catheterization. Number 7. Risk factors: previous history of VTE, genetic clotting disorders, e.g. factor V Leiden, protein CS deficiency, smoking, advanced age, obesity, prolonged immobilization, hormonal therapy, major surgery or trauma, chronic diseases, e.g. COPD, heart disease. Neck 8 complications: pulmonary hypertension due to chronic obstruction and remodeling of pulmonary vessels, right-sided heart failure, cor pulmonale, from sustained pressure overload, lung infarction, necrosis of lung tissue due to interrupted blood supply, recurrent embolism, high risk without anticoagulant therapy, hypoxemia and respiratory failure, sudden cardiac death in massive PE cases. Number 9. Pathophysiology 1. Thrombus formation begins in the deep veins of the lower limbs due to stasis, endothelial injury, or hypercoagulability, Virchow's triad. 2. Embolization. The thrombus dislodges and travels through the venous system to the pulmonary artery. 3. Vascular obstruction. The embolus lodges in a pulmonary artery branch, blocking blood flow. 4. Ventilation perfusion mismatch. The affected area of the lung is ventilated but not perfused, causing hypoxemia. 5. Hemodynamic effects. Increased pulmonary vascular resistance causes right ventricular dilation and strain. 6. Gas exchange impairment, reduced oxygen and increased carbon dioxide levels. 7. If untreated, may lead to decreased cardiac output, shock, and death. Stages of pulmonary embolism. 1. Stage 1, small emboli with minimal symptoms, no significant hemodynamic compromise. 2. Stage 2, moderate PE, multiple emboli with moderate obstruction, dyspnea, tachycardia, and mild hypoxemia. 3. Stage 3, massive PE, large embolus blocking main pulmonary artery or major branches, severe hypoxia, hypotension, syncope, or cardiac arrest. 11. Signs and symptoms. Sudden shortness of breath, most common. Sharp or stabbing pleuritic chest pain. Tachypnea, rapid breathing. Tachycardia, rapid heart rate. Cough, may be productive with blood-streaked sputum. Cyanosis, bluish skin discoloration. Lightheadedness or fainting, syncope. Anxiety and sense of impending doom. Fever and diaphoresis in some cases. Swelling or pain in leg, DVT symptom. Numbers are 12. Medical diagnosis. A. Clinical assessment. History taking. Recent surgery. Immobility. DVT, etc. Physical examination. Tachypnea, tachycardia, hypoxia, leg swelling. B. Laboratory tests. D-dimer test. Elevated and active clot formation. Arterial blood gas ABG. Shows hypoxemia and hypocapnia. C. Imaging studies. CT pulmonary angiography. CTPA. Gold standard for diagnosis. Ventilation perfusion. VQ scan. Used if CTPA is contraindicated. Doppler ultrasound of legs to detect DVT, echocardiogram to assess right heart strain, chest x-ray, often normal or may show non-specific findings. ECG may show right heart strain S1Q3T3 pattern. Number 13, nursing diagnoses. 1. Impaired gas exchange related to ventilation perfusion imbalance. 2. Ineffective tissue perfusion, pulmonary, related to obstruction of pulmonary artery. 3. Decreased cardiac output related to increased pulmonary vascular resistance. 4. Anxiety related to difficulty breathing and fear of death. 5. Knowledge deficit regarding disease process, treatment, and prevention. Number 14. Medical management, oxygen therapy, maintain SpO2 90%. Anticoagulant therapy, unfractionated heparin or LMWH initially. Transition to warfarin or direct oral anticoagulants, DOACs. Thrombolytic therapy, for massive PE, e.g. alteplase, streptokinase. Surgical or catheter embolectomy for patients unresponsive to medications or with contraindications to thrombolytics. Inferior vena cava, IVC, filter, prevents migration of future clots in patients unable to take anticoagulants. IV fluids and vasopressors if hypotension develops. Number 15, nursing management. 1. Assessment and monitoring. Monitor vital signs, oxygen saturation, ECG, and respiratory status. Observe for bleeding due to anticoagulant therapy. 2. Positioning. Semi-Fowler's position to enhance lung expansion. 3. Oxygen and airway management. Administer oxygen as prescribed. Maintain airway patency. 4. Medication administration. Administer anticoagulants and monitor lab values, PT, INR, APTT. 5. Patient education. Explain the importance of medication adherence. Instruct on lifestyle modifications to prevent recurrence. 6. Promote early ambulation. Once stabilized, encourage mobility to prevent further clot formation. Number 16. Treatment options, pharmacologic, anticoagulants, heparin, warfarin, DOACs, thrombolytics for massive PE, surgical, pulmonary embolectomy, IVC filter insertion, supportive, oxygen therapy, IV fluids, vasopressors, pain management, long-term management, lifelong anticoagulation for patients with recurrent PE or underlying clotting disorders. 17. Psychosocial interventions. 1. Emotional support. Reassure patient and family to reduce anxiety and fear. 2. Education. Teach about medication use, signs of bleeding, and preventive measures. 3. Lifestyle counseling. Encourage smoking cessation, weight control, and physical activity. 4. Family involvement. Involve family in care plan and home management strategies. 5. Rehabilitation and support groups. Encourage participation in patient support groups for long-term coping. 18. Prevention. Encourage early ambulation post-surgery or childbirth. Use of compression stockings or intermittent pneumatic devices. Administer prophylactic anticoagulants in high-risk patients. Maintain adequate hydration. Avoid prolonged sitting or bed rest. Encourage leg exercises during long travel or immobility. Weight control and smoking cessation. Number 19. Conclusion. Pulmonary embolism is a life-threatening but preventable condition. Early recognition of symptoms, rapid diagnosis, and timely treatment significantly reduce mortality. Prevention through risk assessment, prophylaxis, and patient education is key to reducing the incidence of PE. Nurses play a vital role in monitoring, management, patient teaching, and emotional support, ensuring comprehensive care and better outcomes for affected individuals. Thank you. Have a nice day.